Good afternoon, everyone. We'll go ahead and get started with this afternoon session. We have a dynamic duo from Gotham City today, the orthopedics and endocrinology. Really delighted to welcome Dr. Emily Stein to talk about bone optimization, and Joe Lane's going to follow with his version as an orthopedist as well. Emily was just telling me she's just been appointed head of SHORE, which is the Skeletal Health and Research at Cornell, which is really a huge program. And we're delighted that she's been able to take time to come out here and talk to us. One of my favorite pieces of work that she's done is the forearm bone density, showing that women who only have osteoporosis in the forearm could still be considered treating. But that's a topic for another day and another discussion. But thank you, Emily.
Thank you. Hi, everyone. I'd like to thank Mike for inviting us to speak. And so Joe and I will tag team this afternoon talking about bone health optimization for orthopedic surgery patients. And I'll begin by talking about how we assess bone health and using anabolic agents in orthopedic surgery. Okay, so these are my disclosures. I thought I'd begin with a case. So this is a 60-year-old woman who came to see us for bone health optimization before having a spine fusion surgery for scoliosis. She had no history of fragility fractures and no secondary causes of osteoporosis. And she did not have DEXA, osteoporosis by her DEXA at any site. And you can see, looking at the table, her lumbar spine T-scores are actually nearly positive 0.2, and the other scores are all about -2. Her TBS was in the normal range as well. So at that time, it was recommended that she have adequate intake of calcium and vitamin D, perform weight-bearing exercises. Anabolic treatment was discussed with her, but ultimately was not started because it was not covered by her insurance, as she did not have osteoporosis, and these drugs are not approved for any other indication right now. So 2 years later, she came back with this very severe skeletal complication. The screws had pulled out and one of the rods had actually snapped. So this case raises some very important questions. One is the DEXA sufficient to screen patients like this for preoperative skeletal deficits? And second, would anabolic therapy have improved her outcomes? So I'd like to talk a little bit about how we assess bone quality in our orthopedic surgery patients, because it's a little bit different than in the standard osteoporosis population. And I'll talk specifically about the spine surgery patients for the reason that those patients have the highest rates of skeletal complications of any of our orthopedic procedures. So spine fusion is one of the most frequently performed orthopedic procedures. There are over 400,000 annually in the United States, and nearly $300 billion are spent on these surgeries and their complications every decade. We have a great need to improve the postoperative outcomes for these patients because currently up to 1/3 will have a complication. And we think that skeletal complications are particularly common in our older patients, and these can include many things, particularly what we call adjacent segment fractures, which are fractures of the bone directly above or below the hardware from a change in the forces, and then also hardware complications like loosening of the screws and breaking of the rods. Successful outcomes after fusion, but also our other orthopedic procedures, require early stability of the hardware in the bone and de novo bone formation. And that's important for fusion, but also osseointegration of surgeries that involve implants. And so patients who have structural or metabolic skeletal deficits may be at particular risk for these complications. Unfortunately, abnormal bone is often not identified until the time of surgery when the surgeons have problems placing the hardware and they say the bone feels soft, or postoperatively when one of these very severe complications has occurred. So there have been several studies looking at bone health and outcomes after spine surgery. The majority, though, are retrospective studies, and most use only DEXA for their skeletal assessment. Several do suggest that low bone density is a risk factor for skeletal complications, but others have not found any relationship between preoperative bone density by DEXA and outcomes. The reason for this discrepancy may relate to the DEXA itself in these patients. So patients who have spinal disease, they have osteophytes, degenerative changes, sclerosis, all of those caused artifact and will falsely elevate the readings, as in the case I presented where she had a T-score of +2 at the spine. Patients who have scoliosis can also be a challenge because that contributes to further inaccuracy and imprecision when we're trying to look at the individual vertebrae. And so many of the patients who present for spine surgery have normal appearing aerial bone density, and that can mislead us about the integrity of their underlying bone. And particularly, we see this at the spine. So there have been studies using other tools to assess bone quality, and these tend to find higher estimates of osteoporosis than those that use DEXA alone. So in one cohort of patients who were referred for preoperative bone health evaluation, either before spine surgery or arthroplasty, about 60% had low volumetric bone density by CT, and that's much higher than the estimates we get when using DEXA. And so this suggests that we need modalities other than DEXA if we're going to accurately assess bone health in these patients. And this is some of our data. So we looked at a cohort of postmenopausal women who were about to undergo spine surgery, and we assessed whether they had osteoporosis using different clinical metrics, DEXA and also FRAX, and then the ACE criteria that I'll show you. So here, okay, so here we have bone density at the lumbar spine. The dark blue is osteoporosis, the lighter blue osteopenia, and this is the percent with normal bone density. You can see almost all of the patients had normal bone density. Very, very few had osteoporosis at the spine. Here's TBS. This is partially degraded microarchitecture and normal. Again, you can see most of them have a normal appearing TBS. None had a TBS in the range that we would consider a degraded microarchitecture. Here's bone density of the femoral neck. We have a little bit of a higher percent here now with osteoporosis, lower at the total hip, and the 1/3 radius. And then here are the FRAX cutoff. So the percent of patients who had a major osteoporotic fracture risk, more than 20%, is here. It's only about 10%. We got a much higher capture with the hip because that threshold, of course, is just 3%, and they were older postmenopausal women. But this was very interesting. This was the ACE criteria. So the ACE criteria for osteoporosis include DEXA T-score, but also history of fragility fracture and FRAX. So together, taking into account then more of those clinical characteristics, we had a much higher percentage of the cohort who actually would have been classified as having osteoporosis. So again, it just reinforces the idea that using the DEXA alone is going to miss a lot of our patients who are at risk. So other metrics of bone quality have been looked at as well as they might relate to postoperative outcomes. And most of this data is retrospective. In one study, higher preoperative bone turnover using NTX was predictive of cervical fusion at 6 months. And this is retrospective, so markers of bone formation were not measured, but it suggests that the patients who have higher baseline amounts of bone turnover may be better able to mount the necessary remodeling after surgery. And in another cohort that we looked at of about 350 patients who had lumbar fusion, those with low preoperative volumetric bone density at the spine had higher rates of surgical skeletal complications. And in fact, what we saw is that the complications occurred about 6 months earlier in the patients in the lowest tertile of volumetric bone density compared to the highest, and that's these circles compared to the squares here. And then Tony Keaveney's group looked with a technique that they've developed called biomechanical CT analysis. So this allows for estimation of the bone strength from the CTs. And again, in a retrospective cohort, they looked at volumetric bone density and low strength and related that to reoperation. And that's shown here. So they classified the patients as either having no osteoporosis in red, having either low bone density or low strength in green, or those who had low bone density and low bone strength. And what they saw is that that was the group with the highest rates of reoperation. So that is all retrospective data, which of course has a lot of bias and confounding in it. And so we wanted to look at this prospectively. And so started this large cohort study called the Fused Spine Study, where we're looking at several different measures of bone quality preoperatively, intraoperatively, and then relating them to outcomes. And this is the first paper. So our first 54 subjects where we had 6-month data on. And we found here that this is an older group. The mean age was about 63. The preoperative DEXA, both aerial bone density and TBS, were largely normal. However, skeletal complications occurred in about a quarter of this cohort in the first 6 months. And I should say they were a higher risk group in general because they had these very long surgeries that involved hardware in multiple bones. We found that DEXA did not predict complications, but we looked with this more advanced imaging tool called HRP-QCT, or high resolution peripheral QCT, that allows us to measure the volumetric bone density and the microarchitecture, or the microscopic structure of the bone in our patients. And when we did that, we actually saw that the patients who had abnormal volumetric bone density and microarchitecture by HRP-QCT preoperatively had higher rates of early complications. And specifically, it was the patients who had lower trabecular volumetric bone density, fewer and thinner trabeculae, and thinner cortices. And you can see looking at these images. So here's a 70-year-old woman in the cohort who did go on to have skeletal complications compared to one who did not. You can just see qualitatively the amount of trabecular loss in this woman's radius and her tibia scans. So these results highlight the importance of bone quality in fusion success, and they also underscore the limited ability of DEXA to detect abnormal bone and predict complications in these patients. And here's some other data that we more recently published looking at specifically the postmenopausal women in the cohort. And we looked at what factors were associated with complications in the women specifically. And we found 3 things. So a greater number of fusion levels. So again, the surgeries that involve more hardware in more bones are more likely to fail. Thinner cortices, the cortices are where we put in those screws into the pedicles, and smaller bones in general. So those were the factors that conferred the most risk in these older women. And these figures here show it broken out as cortical thickness and total area in tertiles, and then according to the number of surgical levels. So the dashed lines are patients with fewer than 6 levels, which was our median. And here are the patients with 6 or more levels. And you can see that for each tertile of cortical thickness, the risk is greater, but that it is also greater in the patients who had more surgical levels compared to those who did not. And the same thing for total area. So we see the greatest risk in the women who had smallest bones and the longest surgeries. So these are factors that I think we can consider in our patients, especially as we accumulate more data to really show us what is most important in conferring risk. But if we are able to identify patients who we think are at high risk, is there anything that we can do about it with anabolic therapy? So there have been several studies looking at anabolic treatment in spine surgery patients. Most of this data is from observational studies, so not clinical trials. And the few interventional studies that we have some limitations. They lack controls often, or true randomization and blinding. And so it's important to remember all of that when looking at some of this evidence. All of the published data so far is with teriparatide. So one study looking at preoperative treatment, they compared postmenopausal osteoporotic women who had received preoperative teriparatide for at least a month compared to those who did not. And they found the ones who had been treated had higher insertional torque of the pedicle screws at the time of surgery. So that means they required more force to put in those screws compared to the women who were not treated, suggesting that the bones were stronger. And this study, again, it is not a clinical trial, is actually used to be the basis for some of the recommendations that we do start treatment preoperatively. Studies looking at postoperative treatment compared to no treatment suggest that there's greater bone union by CT in treated patients, that there may be a lower prevalence of screw loosening, and perhaps that a longer duration of treatment, again, this is observational, but the women who were treated for an average of 13 months compared to about 6 had better fusion both by X-ray and CT. There have been papers comparing postoperative teriparatide to bisphosphonates. Again, not clinical trials. They suggest that there are earlier fusion rates with teriparatide compared to both oral bisphosphonates and zoledronic acid, but it seems as though the differences in fusion and complications are really no longer apparent beyond 12 months. So this is one of the few clinical trials. It's from Japan, and so they gave weekly teriparatide for 6 months compared to no treatment. And the patients and the study physicians were not blinded, but they did fusion assessed by CT 2, 4, and 6 months. The radiologists were blinded and they gave a fusion score. Now here, looking at these figures, it's important to know the lower the score indicates more complete fusion. There were 25% dropout rate in the teriparatide group, and they did not see any difference in their intention to treat analyses. But in the per protocol analyses, they did find that there was more fusion in the teriparatide, that's these black circles, compared to the untreated patients in the white, both unadjusted and age-adjusted analyses. But again, this is a reasonably small study with some important limitations. Not all studies have found benefits. So these are 2 clinical trials that found no benefit of teriparatide, but it's important to note they both were unique in certain ways that may have limited their generalizability. The first was a study of non-instrumented fusion. So almost all of the surgeries that we do have hardware put in the bones. Here, they didn't. And the second trial just had very, very high rates of failure, about 60% that weren't fused at 6 months and 32% screw loosening. So it's unclear how to interpret these. Also, they didn't have sample size calculations, so perhaps were not powered. And in terms of the other anabolic agents, animal studies have shown that both abaloparatide and romosozumab promote fusion, but we don't have any publications yet. Our group is conducting an ongoing randomized double-blind placebo-controlled clinical trial, which we call the Fast Healing trial. I'm leading that with Jerry Nieves. And here we're looking at postmenopausal women who are having their initial instrumented spine fusion and looking at 6 months of treatment and whether that will promote fusion and lead to better outcomes by CT at 12 months. So we'll see. Hopefully this will give us some important data. So I'll also talk a little bit about arthroplasty, and then I know Joe is going to spend some more time on that. But what we think about in terms of bone quality and anabolic therapy in those patients as well. So historically, arthroplasty used cement to maintain the position and stability of the implants, but more recently, there is an increased use of these cementless procedures, and they require osseointegration or bone growth into the pores of the implants for stability. And so that has led to a lot more interest in bone health in the patients who are having these procedures. We want to know whether they will be able to be successful when they do that. And we do think that bone health is related to outcomes because there have been studies showing that prior fractures and low bone density are related to an increased risk of complications after arthroplasty. The skeletal complications in general, though, following arthroplasty, which are aseptic loosening and periprosthetic fractures, are very uncommon. So their incidence is about 0.5 to 4% after hip and maybe 0.5 to 2% after knee arthroplasty, with the higher rates in the revision surgeries. So because they are so uncommon, it is very challenging to design a prospective study using these as outcomes. And so there's interest in looking at different surrogate measures, which may help us infer the risk of these more serious complications. So some have used implant migration or the movement of the implant as an outcome, and low bone density has been related to implant migration following both knee and hip arthroplasty. And migration of tibial implants was associated with actual aseptic loosening, which is our more severe clinical complication in a knee arthroplasty study as well. We know that there can be periprosthetic bone loss after both cemented and cementless procedures. And because of that, some studies have looked at changes in the periprosthetic bone density as an outcome as well. So most of the studies looking at different pharmacologic treatments in arthroplasty have been very small, observational, and they focus on these short-term and surrogate outcomes. It appears that bisphosphonates do prevent periprosthetic bone loss after both hip and knee surgery and may be associated with lower revision rates after knee arthroplasty. Denosumab also has some data showing that it prevents periprosthetic bone loss and may decrease early implant migration. And the anabolic agents improve osseointegration in animal studies. The human studies to date are all using teriparatide, and these have really only looked at periprosthetic bone density change, but there is an ongoing study of the baloparatide in knee arthroplasty patients, so that will be very useful to see their results as well. And so this is just one study, again, quite small, where they looked at teriparatide and changes in periprosthetic bone density after knee arthroplasty in postmenopausal women. They had 17 women who had 22 knees operated on, who were treated for 12 months and compared to a historical control group. And they did see that with treatment, there was a significant increase in bone density, and at 3 specific sites shown here in the circles, the anterior and posterior condyles and the tibial diaphysis. So I think it's clear that bone quality does play an important role in outcomes after orthopedic surgery, and poor bone quality can result in different complications, including fractures, diminished hardware stability, and decreased fusion. DEXA may miss osteoporosis because of artifact from underlying spinal pathology, and other modalities like CT measurements of volumetric bone density may provide additional insights regarding the underlying bone of our patients. In terms of perioperative treatment, some studies do suggest that anabolic treatment has favorable effects on spine surgical outcomes, but the finding is not uniform, and we have very few rigorous clinical trials. The human data that we have to date is all with teriparatide. It suggests that there's faster rates of fusion with treatment, but the long-term differences in fusion are less pronounced. And the beneficial effects seem to be most clear in older patients who have preoperative osteoporosis. In terms of arthroplasty, both anabolic and anti-resorptive treatment appears to mitigate periprosthetic bone loss and perhaps increase the periprosthetic bone density. Anti-resorptives may reduce implant migration. We just don't have data on the anabolics in that regard, but we have very limited data investigating the treatment effects on clear surgical outcomes, which again are very challenging to study because they're not very common. So in conclusion, based on what we know now, patients who are known to have skeletal fragility preoperatively should receive treatment, which is indicated for their underlying osteoporosis and may also have a benefit for hardware stability, promoting fusion and osseointegration. I think we should consider treatment for the patients who we know have risk factors for failure, but we really need additional data from controlled interventional trials so that we can improve outcomes for the growing population of older patients who are having orthopedic surgery. So thank you, and I will turn it over to Joe.
You want to take questions now, or you want?
Oh, either way.
We've got just a couple of quick questions, if that's all right.
Good job.
Can you say a little bit more about Hounsfield units prior to surgery and how much you rely on those as opposed to some of the other modalities and how valuable they are?
Yeah, so we have at HSS a software called Mindways, which is fairly automated and based on the CTs that actually has an asynchronously calibrated phantom. And so we get a value for volumetric bone density directly when we do that. But if that is not available to you, you can use Hounsfield unit measurements as sort of a quick tool for assessing the bone on the CTs, and that has been published by several groups. And I do think it is helpful and it will relate to the bone health, but you have to keep in mind technical issues that may limit doing that, any heterogeneity in the bone because you're really just picking one small area. And we know that these patients' bones are abnormal and we see it influencing the DEXA the most, but it influences the CTs as well. And so I think you have to be very careful in just using that, because if you don't have a very homogeneous bone and you're just picking one area and getting a Hounsfield unit and taking it to mean, usually I think the risk is interpreting the bone as being healthier than it is, that would be a problem. But as long as you're looking carefully and also taking into account contrast, there are different thresholds if you do or do not have contrast in your CT, that it can be a useful thing. And I think, I think we have to use what we have available. And so that's often a very good idea and something that we can do, especially if the patient has had a CT for another reason. To use it opportunistically, I think is a great idea.
One audience question.
Hi, Emily, Mike Collins from Bethesda. That was a really good, clear talk. Thank you very much. Something just occurred to me and it relates to this last question is we've started to use, and there's now available, and maybe you're aware, and maybe others, is the photon counting CT. It's a new CT. It provides greater resolution than either HRPQ CT. You can do any bone in the body. So it could really be a useful tool for you. We're starting to use it. And I know HHS has a lot of money, so I'm sure they can afford one there too.
Yeah, so I am aware of people starting to use that as well. We haven't, but I think, again, I think it's a great thing to do because we need additional data. Just using the DEXA isn't going to be that helpful. So I think if it's available, it's certainly something to take into account when you're trying to understand someone's bone, because the issue is it's just very frequent that we are being alerted to someone having poor bone quality because the surgeons call us and say, I did surgery, the bones felt soft. And that is not when we want to know about it. Or they get referred to us from somewhere else because they've had a complication. So I think anything that we can do to know before we go in that there may be an issue, because it can change, certainly can change if we try to give them some medication. It can change the surgical planning as well. The surgeons do different things depending on what they think they're gonna and what they think they're getting into. So I think, the more information we give them, the better it is for all of us. So yeah, thank you. All right.
Great, thank you. You'll hang around, we got it. Great.
Okay, we're going to have a little fun. We're going to try to be pragmatic. I am depending enormously on you to beat up my colleagues. You know, these guys, if there's no doorway, they just walk through the wall, yeah. But the reality is that if you take the problems in orthopedics and you do an operation, if it's a bony procedure and you look at the failures and you say, gee, I did the operation, it's perfect. The x-rays are perfect. The thing they didn't take into consideration is the patient. Patients are different. And we're now realizing that the failures are related and many times related to the quality of the bone. The big problem for us is identification before the operation to decide whether you should even operate. Number two is there any way you can do something beforehand to make it better? And you'd like to, or at the time of the surgery perioperatively, to make them get through the situation. And they're going to come to your office, they're going to ask for help. So I think we're going to try to give you an approach of what we learned the bitter way at our institution on how to do this thing. All right, so there are, I think I get money from everybody, so I can't be conflicted. So Emily really raised the question about the quality. It's interesting, right now we're going to robotics and we're doing all this imaging beforehand to prepare for surgery. Why can't we take advantage of those instrumentations to give us an answer even before we operate? But each company has their own little system. So it is not an easy match to work it out because there's the Makos and all these different systems. Anyhow, In spine fusion, 30% of spine fusions are not going to go well. They're going to go south of the border. And the question is, you need to treat them, and do you have enough time in advance to fix it? There are some tricky things we can bring up in discussion about that, but you really need to treat it until they heal. We're talking about a 1-year course of some sort of therapy afterwards to fix this situation. Conversely, if you look at hip arthroplasty, we really don't have big problems in the first year. It's 1 to 2%. We're looking to the future. So, but the point is, we're going to talk about the future, and it's usually missed. And once you miss it in the beginning, you miss it at the end. Now, we did a study at HSS in on the arthroplasty group, and we asked the question, how can you find people that are at risk for osteoporosis? We took the guidelines, women over 65, men over 70, and we asked if we did a frax on them. We just did a frax. And we either use the general fracture or the hip fracture rate. And we said, what percentage of people are in this group? Well, it turns out it's close to about approaching 65 to 70% of women over 65 will fail this test. So the overwhelming majority of people in this age group really need to be addressed somehow. And we did this 3 times. We got the same result each time we did it. So in the past at HSS, Total Hips with a diagnosis of osteoporosis. We were very diligent. We wrote this beautiful letter out to the primary care doctor. We asked him to treat the patient. We begged him to treat the patient. And you look at him 1 year later, 20% were treated in our best series. We've done this multiple times. People, the letter goes to the primary care doctor, secretary puts it in the folder. You don't look to the folder until you see the patient. You got 8 minutes to see the patient. Who has time to go through the folder? And you're going through a little bit with diabetes and heart disease. It's a lost cause in this situation. So this is not a successful method to do it. And we got tired, and we realized that we're repeating the same story as the fracture liaison service. So there's a high success there's a high successes in arthroplasty, and the orthopedists are not interested. They don't see the problem on their watch. So there's lack of interest in addressing the problem of osteoporosis. And this is why you have to nudge these people. And the most common form of failure, if you go and then look at when it fails, is local bone failure, local bone. So it is the cause, it's just happened so quietly. Most of these guys have stopped watching their patients long before this becomes apparent. So this is what you're up against when you're dealing with these people. And then the other question is, how much does osteoporosis affect this prosthesis? Well, there are 2 things. There's the long-term effect of osteoporosis, which leads to endosteal resorption. And you go from a shape like this to a shape like this. So there's a change in the fit for the prosthesis. Many of these people, the hospitals buy one system fits all for all patients. Doesn't fit these patients. So they're using the wrong prosthesis in this question. And when we look at the question, it's due to fit and fixation. Can they get the fixation? And finally, what about the quality of the bone? And we asked this question, and it turns out that in subsidence of the stem, it occurs when they take their first step. You're not going to get a drug in there that's going to stop that from happening on the first step. So the question for them is, should they really cement the patient or not? And this is a question that has to be brought up. You should ask that question of them. The misfit of the prosthesis, and that therefore the pre-treatment with osteoporotic drugs are not going to change fit in these particular patients. So it's going to be, your job is going to be looking to the future and preventing fractures. You do not have enough time to fix the bone when somebody needs an arthroplasty, unlike the spine that Emily talked about. So, so the question is, what should we do? And one of the best methods is, the question is, should you use a drug, a simple drug that's going to be more universal? And we already have this answer from Ken Lyles. And what he showed is, if you use zoledronic acid and you give it to the patient, you can dramatically decrease fractures all over the body as well as locally, but you have to pick the time. So if you want to get the drug into the area around the prosthesis, you got to do it in the first 6 weeks. If you wait to over 3 months, it's going to be generalized, because the area around the fracture is hungry, and that's why the bone scan's positive right away after you do a total hip. So you have to decide, if he says it's local, I have a local problem, then you better give that drug quickly. If there's no local problem, you could wait to a longer period of time to give that particular drug. So this is the issue, and I would go back. It was in New England Journal of Medicine. The article is just as pertained. He did it in hemiarthroplasties for fractured hips. I know the patients are a little bit more difficult and more likely to fracture, but the principles are basically there. And there's the documentation for why you want to do the Ken Lyles' approach. So the other question is, what about anabolic agents? Well, is there poor biology? If I tell you the patient's on 20 milligrams of prednisone because they have lung disease, that is going to be bad bone. So that's going to be bad biology. So you've got to get a history of their underlying medical diseases, and are they on a drug that's doing something deleterious to it? Number two, if they insist in putting in a non-cemented hip and they have a bad fit, you're not going to jump the gap. You say, what's a good fit? Well, the orthopedic, oh God, if I'm within 1 millimeter, that's a good fit. Well, 1 millimeter is 1,000 microns, and the actual osteoblast is only 6. It's like crossing the Grand Canyon. So that basically you need special drugs you need something to do this. And certainly is thigh pain is a marker that there probably is some loosening in this issue. So if it doesn't look good and you see a space, that's where an anabolic agent may be warranted, particularly in a non-cemented hip, rather than using the zoledronic acid. So the approach to arthroplasty, they look at diabetes, pain management, weight control. By the way, the question is, now they're putting all my patients on these wonderful drugs that lose 10, 15, 20, 30 pounds. But, where do you think they're getting where is it coming from? Well, they're not going to get it from the brain and the heart. They're going to get it from the musculoskeletal and the bone. And I don't know if you've noticed it, but I'm seeing profound osteoporosis the more the patient loses weight in a very short period of time. So they should probably be protected if you're going to do that. But we need data on that material. But post-operatively, we think we should do the same thing. How many here have a fracture liaison service at your institution? Well, I think you got to change the name to bone liaison service, and it should include the same protocols for these kind of patients that you would do for hip fractures. You should do for spine, and you should also do for arthroplasty, people who are at risk. And I think it's very important to do this. And what we do is we identify these patients. We give them 1 year of quick treatment because we know we have plenty of time to work on it. We use the Ken Lyles system, probably more likely, unless we have a problem for the. And then we hand the patient off. It's been shown over and over again. If the patient is on a drug, when you send the patient out to their primary care doctor, they'll continue the treatment, what you do. Now, in terms of, so our osteoporosis treatment following arthroplasty for femoral neck is associated with low rates of periprosthetic fractures. Oral bisphosphonate is economically feasible, and it's easier than starting the reclass at our hospital. I can't get them on the list to get their reclass their injection. It's very difficult and they don't want to come in. So many people are at a distance. So we tried to do the orals. If the orals don't work, we'll go to zoledronic acid. Okay, now 80% of fracture patients are never screened for osteoporosis or treatment. And so we realize this and we have a fracture liaison service, but we failed in many ways. The patients come in to see their doctor, not to make an extra appointment. And if we try to make an appointment with our boneheads, our best bone people we had, or our nurse practitioners, we could never get beyond 54%. They just didn't show up. So what we did is we learned this from our friends down at Methodist Hospital. We embedded the fracture liaison service right in the trauma unit with the trauma doctors. So when they come in to see the doctor for their hip fracture or whatever it is, the nurse is right there to start the discussion. The second thing we learned is from the pandemic, we discovered telemed. And once they know your name and they've seen him, you've seen them, most of this can be done at a distance. The one thing I do know is patients won't make an extra trip in to see the bone person. So you've got to take advantage, but you've got to be there. And the other thing is the doctor who's treating the patient has to say, look, this is my partner in crime. I want you to listen to this person. If you do that, the patients will pay attention. But so we have unequivocally, we have two systems. One at HSS, we make the appointment, we can't get past 50%. And then at our trauma unit, we're 84%. The nurse is right there. They're right there. And I think this is so important. I'm going to bring up, now I'm going to go into some areas that you may or may not. How many here send patients or associate with patients to get kyphoplasty for osteoporosis? You see a lot of it. All right. So kyphoplasty, it leads to rapid pain relief, height restoration, and prevents collapse. The problem was there were two articles which were negative in the study, but in those patients to enter into the study, you had to lie on your stomach for 1 hour without a sedative so you could be fooled by the doctor. Well, I'm not sure. That's about 2% of my fracture patients. And yes, in that group, kyphoplasty will not work because they don't have enough pain. But the truth of the matter is kyphoplasty is a successful operation. However, it has a problem. 26% of people who get kyphoplasty will have cement in their lung. Now, well, they don't mind it. It's not so bad. It's not a big problem. And of course, the interventional radiologist never sees the patient anyways afterwards, so they're not quite sure what's happening. And then, of course, there are over 100 patients where they have to take the stuff out of the heart. So it is not a perfect operation. So yes, it gives relief, but there are some side effects of it. So, the question came up, why are we using cement for all these? Now, why am I talking about this? I'll get to it at the end. Why don't we use something that's more reliable? That will not go anyplace. So we use these little beads of bone. It's a necklace. And these necklaces are allograft bone. And instead of putting in cement, we just bang in these little beads and we tamp up the bone. It is impossible for these beads to go anywhere other than stay in that location. And they fit through the cannula. It works the same way that the kyphoplasty works, except instead of using cement, we now use these beads. Now, at the time that we've been doing this, we now realize we've had better success with anabolic agents after a fracture. And we saw, could you load these beads up with anabolic agents? So we have now working with the group at Brown have shown that we can then soak the beads in teriparatide or abaloparatide. It'll hold the material for 13 days, 14 days, and it still delivers on a daily basis a therapeutic dose for at least 2 weeks. And in some models, tissue culture models, we've shown osteoblasts produce high alkaline phosphatase. So the point about this beads is that you have the option to use it in combination with drug therapy locally to try to heal this particular bone. So what happens is here's our first experience with using this technique. We can go in to make a cavity, or we can just bang it in, let the bone find its best pathway. And in the lower tables are the reported reports for pain. On the left, it's for 3 months, and the right at 6 months. And when you compare it, the yellow is the one in which we do not make a cavity, and we get the same results. So you can get the same results of pain and function in these patients without the chance of having cement going to the lung. And the reason is, if you look at perivertebral veins on the studies on the right, you see varying degrees of the cement in the vessels outside the vertebral body on their way to the lung. Yet in the ones that are treated with the impact bone, there is no material that is in the veins, and it is safe. Here is an example of before and after you put these beads in. We see we can maintain the height. If anything, we get about a 10% improvement in height restoration. So that with this kyphoplasty, they're comparable to cement. There are no embolizations. And the issue is, this has the potential to carry the drugs that we want to do for local fracture healing. You could use, and we're working now with abaloparatide and teriparatide to soak these bones and then lead to local distribution. We've now tried to use this principle for AVN and for when they put the pedicle screws in for the spine. This is a way to build up local osteoporosis care, and at the same time, you have the potential to put your cocktail in of some of these agents to lead enhanced care because of the osteoporotic drugs. So in osteoporotic and osteopenic patients, we think these patients really carry bad bone in up to 65% of people over the age of 65 that are ignored and not taken care of. You're the only ones out there, I can assure you the orthopedists are not going to do this, to convince them to screen their patients. Emily has shown you a series of tests that she can use that will alert you that there is a particular problem. And we're doing well with the spine group because they have a 30% failure rate, and they know they have to do something. But the other people are out there and they're not paying much attention, but they also need to treat these particular patients. So if you can diagnose that they have a problem, we have drugs to offer, just like the fracture liaison service, and we should be doing it. The big challenge right now is to show efficacy and to develop the best approach. I'll give you a setting. So your patient comes in and has osteoporosis. You want to enhance the bone. They're willing to wait around 3 months before surgery. Which drug are you going to choose? You're going to choose Romo, or you're going to use the PTH agents. PTH agents are 2%, let's say 8% per year, 2% in 3 months. Romo, almost all of its bone building action is in the first 3 months, which is 11 to 12%. Maybe we should use that drug up front for 3 months before we go on. But on the other hand, after surgery, there's very little data that Evenity really is that helpful for spine fusion and jumping gaps. We may use the PTH products. So you will take common drugs, but you'll develop a sequence of events that will lead to a better successful operation. This is where we need research and studies to look at this. The beauty about the spine is it's a similar operation with a similar problem, big numbers. and it's easier to get an answer. Very hard in the other areas which are much slower, where you don't have, you have to get surrogates. But think about these drugs carefully and make them as part of the story of the patients who are being treated. Thanks a lot.
Mike, we'll go ahead and do your question, then we'll go to online.
Hi, Mike Lewicki, New Mexico. Fabulous presentation from both of you. Really appreciate it. I'd like to go back to Emily's case, which I think is important because it's representative of many patients that we see in practice who are about to have major spine surgery, don't meet the usual criteria for treatment with anabolic therapy and may not meet the criteria for any osteoporosis therapy. Yet they may be at high risk for complications from surgery. So tell us a little bit more about what we should do to further evaluate these patients and how to get them on the treatment they need.
So I think that's a great question, and it's not one with a very easy answer right now because, as you said, the medications are often not covered even for patients where we think that they're indicated. So they're not covered for fracture healing. They're not covered for perioperative healing, even though they may be beneficial in those settings. So I think taking into account any of the clinical characteristics that we know confer risk. And so we can try to make a case with those. If you have CT available and you can measure Hounsfield units, a lot of the hospitals do have these systems now that you can look at the volumetric bone density. I think that can also be used to make the case for treatment. But oftentimes, it's precluded by cost and the patients aren't able to cover it out of pocket and we're stuck. So it's a challenging situation. So I think the best we can do right now is to use any modality we can to provide evidence of an increased risk, and certainly a low bone density at any site I would take in these patients. We have the general patients who have a low 1/3 radius, but I think in these patients, the spine is not going to be up. The spine is just not going to be low. A lot of times they've had arthroplasty. We can't even look at their hips, and maybe the wrist is what we have if that is something that they measure at your institution. And I would take those measurements seriously if that's what you have, and also realizing that the DEXA does have some artifact for bone size. So patients who have smaller bones are likely to have a lower DEXA T-score. And that also is something that I think we're seeing is associated with increased risk of complications.
Mike, there's one other thing, Mike. Many of the people you get to the hospitals will clear the patient for surgery. They just want to make sure they're not going to die on the table. They need a full history. And when you really look at the history of many of these patients, there are other reasons to make sure that they get in. And I like Neil Binkley. He has these 6 criteria. Any one of those are positive, he'll fight the battle, the good battle.
Yeah, there are a lot of questions online about trying to get insurance companies not only to pay for the medication, which I think you've addressed, but also the studies in advance. HRPQCT is clearly not part of insurance companies' coverages, correct? Or have you gotten it paid for?
Right. So HRPQCT is only a research tool right now. So that's something that we're doing under research protocols, but it's not something that you can take into your clinical picture yet.
Trabecular bone score is.
Trabecular bone score,
Tony
CT.
Kidney's BCT.
Yeah, Tony Kidney's BCT you can do, and volumetric bone density by CT. So I would say use what you have access to.
And Dr. Lang, could you go back to this decision that you mentioned, Ken Lyles, whether you should give the reclass at the time of the fracture, and how you make the decision whether you're going to try to concentrate it at the site or wait and see if you can prevent general osteoporosis fractures? Yes.
There was a study that came out of Austria where they gave zoledronic acid within the first week, and then they had these double beads and watched the migration of the cup, and they dramatically decreased the migration. So You can concentrate it. If you knew that it was soft as you were putting in some instrumentation, or your screw was not tight, you would want these, that's when you want the drug there to protect the bone. If everything is perfect, you can wait a little bit longer, and if they're more generalizable for osteoporotic care. But I'm leaning more toward, I like to split the difference, and I like to look at like 4 weeks to 8 weeks. I'd like to get the drug in. There'll be a good percentage will be in the local area, and you will see the Gruen zones will be narrower, and I think it'd be to our advantage.
All right, we'll go to Andrea.
Thank you, both of you. Fantastic talks. Andrea Fox, Fracture Liaison Service at Stanford Healthcare. Sure, Mike Gardner would say hi if he knew I was talking to you right now. So we see a lot. I think about 40% of my referrals now are for spine optimization prior to surgery. These patients come to me and the neurosurgeons, orthopedic spine surgeons say, Andrea, let us know when you think the patient's optimized. And of course, there's no way of knowing, right? We do the best we can. I always tell these patients, hey, I'm here to treat your entire skeleton. I know you're here because of your spine and you want this surgery electively and you need it, but I'm here to treat all of you. So that kind of sets that pace. But I'm real curious to know, because there is such a delay sometimes in their surgical intervention based on how long I want to optimize, 3, 4, 5 months, whatever their case might be, that I'm afraid, because they're all immobile, they're in so much pain, they're not doing anything. And the amount of bone loss that they have is something that I take into consideration also with the timing that I might recommend back to the surgeon as to when to step in. Can you tell me, have you had the conversations in that space and what your thoughts are? And will they be losing more if we don't get to surgery sooner? Thoughts on that?
I split the difference. I think 3 months is a good thing. First of all, these surgeons not going to complain. The patient's not going to complain too much. And I'm intrigued. I'm intrigued with Romo about this. I looked at this profile and we've been discussing it in our bone unit here. We looked at the time in which you can get a big chunk of bone in there very quickly. It's a strange way that drug works. But I still think 3 months will do the job for you. And then, but you got to remember, you have to pick your drug for after surgery. And I still think the PTH drugs are, right now, there's more data to support than the others. The others, you're going to have to do research on that.
Thank you.
But I would just add, I think it depends on where you're starting from, right? So you have to think individually about the patient and how severe is their bone disease at the outset, because again, you need that anchor. That anchor is the first part of it. It's not the final, but if it's someone who has really terrible bone based on any imaging or based on their fracture history, you might want to give them a longer course of treatment because you really want to maximize the amount of bone that you have at the time of surgery.
Steve Harris, San Francisco. I just wanted to thank you as well for 2 lovely presentations. Emily, I'm going to ask you the same question that Joe just responded to. So given everything that you know and all the ambiguities, what treatment agent for how long prior to spinal fusion?
Yeah. So as I said, I think you have to think for duration. We do not have good data to tell us. There are some expert guidelines that have been published, and even the data that I showed, recommending pre-treatment, it's from observational studies based on people's clinical practice.
I know, but you still have to do something, Emily. So what are you going to do?
I would say depending on how severe their bone disease is. If you think that the issue is, it's somebody who's at risk, maybe based on the complexity of the surgery, they have bone density that's low, but not a history of very significant fractures. I think that's someone that you don't have to have a long pre-treatment if you can do 3 months, because it's taking time anyway to get all these other things done. I think that is great. If you need to start it at the time of surgery for someone, in that case, I'm comfortable doing that. But if it's somebody who is very high risk based on their history, then I think that is likely not sufficient, and we have to go longer, balancing their pain and disability and everything else. But I mean, we see patients a lot of the time where the surgeons will not do surgery, because they have this awareness and they know what's going to happen when they try to put the screws in. So that may be someone who needs a full year, but it's not evident. It's not based on good evidence. It's based on our best clinical assessment. But I do think that, you know, having one specific timeline for all the patients isn't something that really necessarily makes the most sense.
There's
Fair
a
enough.
great study done by Emily. She looked at the physiatrist to give steroids to, you know, get their injections. Some of these patients at HSS have had 18 epidurals. Every single epidural, they lose bone. Every single one. So the question is, when do you start? Well, if you're going to do an intervention, our colleagues are doing an intervention on these patients when they come in and you say they may come down the road for, that's when they should start their osteoporotic care. Then it's more likely we have plenty of time to get things fixed up. But I'm particularly these steroids, you know, Emily, it's your work, not mine.
Yeah. Hello, I'm Dr. Rita Roy with the National Spine Health Foundation. I want to thank the presenters for the excellent presentation today. And I really just wanted to share with the audience that National Spine Health Foundation has created a spine and bone health task force. Many of your colleagues are part of that, that group, and wanted to let everyone know that we are starting a bone echo program that will launch this September on spine optimization for surgery. And that we're very excited for the CME that we are going to be putting out. And our task force is being very, very involved in putting that together. So I wanted to thank you for this and wanted to just let everyone know that I'm going to be here for the next day and a half and love to talk about that.
Thank you. Yeah, that's good news. Paul?
Well, thank you, Joe and Emily. That was great. I see almost all of the spine surgery patients in the city of Denver. I've been there a long time and they all know me. So, and they believe what I have to say, even though, and I see a lot of the patients who are up for their second and third fusions. And years ago, we started using Forteo, and now much more so Timlos, for 3 to 4 months before their surgery, and then continue it, usually for their systemic condition, continue that. And anecdotally, they're all just tickled to death in terms of the outcome. There's a paper that I fall back on that I send to the insurance companies when I try to battle them on the payment of this stuff. It's by Zhang in the Journal of Orthopedic Translations, 2021, a review paper on the use of PTH in facilitating spinal fusions. So I'd just make that comment. I'm fortunate that I can get a lot of samples because most of the times I can't get it paid for. And these people are very grateful. So thanks.
Art Santoro, an endocrinologist to establish my bias. These are both superb talks. So actually I'd ask the question, and you probably are in a good position to comment on it. Should we really be diagnosing osteoporosis or saying this patient does not have osteoporosis if they have tons of spine osteophytes, they're 65 years old? You know, the chances are probably about 80%, 90% that she has osteoporosis. So maybe we should be reading out DEXA reports as saying there's a reasonable possibility this patient has osteoporosis, and just act, you know, and actually the plans you both outlined are really superb. If I wanted somebody, if one of my friends, relatives, or patients, I'd want them on Forteo before, you know, they have a surgery where it's likely for, you know, a pedicle screw to pull out. So I'm sorry to make it a long-winded comment, but maybe it's just the way we're diagnosing osteoporosis in this particular patient population needs to be rethought.
I think
I agree.
he's right. Look, if somebody is coming to you with back pain, you're going to have a back surgery, you know they have arthritis. So the DEXA just is not valid, is just not going to be valid in that patient. And we see it consistently. We go from osteopenia to, I mean, even normal to osteoporosis when you do the CAT scan.
Last
Hi,
one.
Deborah Cotto, Stanford. I'm a geriatrician, and so much of our patient outcomes have to do with premorbid function. And clearly, spine surgery is not to be taken lightly. But in my experience, it's those patients who really work with PT, and granted, it's pain often that drives them, right? But that really work with PT and get not only the medical treatment that you're talking about in which order and for how long, but also really talking about core musculature, things that they can do to work on during that same period. And I'm just wondering if that's part of your practice. And if it is, we should really talk about it because that can make the difference to have people feel as much as possible with their pain to really focus on muscle strengthening. And I think Andrea mentioned a little bit about treating the whole patient, so function all over in terms of muscle body strengthening.
Yes, absolutely. That's a great point. And we have a very large physical therapy group that we work with. And I think it is an extremely important component to the outcomes, to their recovery, to their falls, and a lot of the complications that they'll incur that may affect the bone. So thank you.
Real quick, last one. We got Dr. Collins coming up next. So short question.
Okay, so I think until we make it a standard of care for treatment of fractures, hip fractures, that you have to have a bone density and an evaluation for osteoporosis, until you make it a standard of care for spine surgery, that you have to have some evaluation for the bone health of the spine, it's not going to change very much. Although the spine surgeons are getting a little bit smarter for this. I think the study that you need to do for total joints is survival of the prosthesis, periprosthetic fractures, 5 years on people not treated and people treated with that. That will get the orthopedist point of view, because they don't like to have to, if you look at the number of revisions that are occurring, a lot of them for just the same reason that you pointed out.
Thank you. Okay. Thank you all.